Well, thank you everybody for being here tonight. We appreciate your time. My name is Shannon Bennett. I am the program manager for the Nevada State Immunization Program and have therefore been charged with COVID-19 vaccine rollout for the state of Nevada. So we have been working on this, really started planning over the spring and summer as we could kind of see the writing on the wall, but things have been moving very, very quickly. And we are really seeing a lot of changes, a lot of fluidity in this whole planning process. Even today, things have changed even today. So I think we will continue to see that as we move forward. And I am joined by Dr. Pam Forrest with me today as well, and she will be able to answer any clinical questions or take deep dives into that piece of it as we get there. All right. So today we're going to go over the COVID-19 vaccine playbook. We're going to go over the timeline. We're going to go over a little bit of vaccine detail, a little bit about storage and handling because some of this stuff's a little different than we are used to seeing. A little bit about our prioritization and allocation methodology, data reporting, and then ultimately COVID-19 vaccine clinical trials. So on September 16th, the Centers for Disease Control and Prevention released the COVID-19 vaccine playbook for jurisdictions and requested that every jurisdiction in the country created their own version of this document. We did that. We had to submit it by October 16th. It was a very quick turnaround. And we have this link on this screen is the link to the CDC's one. I need to update my slides because we have released ours for the state of Nevada. Now, what's very important at this point in time is this is just a framework. It's just a foundation, if you will. A lot of pieces need to go into this still. A lot of detail still needs to be ironed out. And as I mentioned at the beginning of our conversation today, we're still learning. We're still learning new things every day. I feel like multiple times a week, the CDC or Department of Defense comes at us with some new piece of information. So while we did put something in writing here, we will be continuing to update this and continuing to work with partners to develop specific strategies for each population as we move through this process. So a little bit about timeline. We are right now on this graph way over here on the left. Of course, we're still in clinical trials. We're still moving through that process. We don't have any vaccine available to the state of Nevada yet. Now, we are expecting that to change relatively soon. We are being told that we have to be prepared by the middle of November. The Pfizer vaccine looks like it may be coming out first. That was looking pretty promising in clinical trials so far, and maybe heading for potentially an early December launch. So this timeline here, as you see on your screen, is broken up into 3 chunks. The first chunk in phase 1 is really looking at limited doses, and we anticipate that to be the situation for a while in the state of Nevada, that we will have limited amount of vaccine available to us. It likely will not cover all of our populations that we need to cover, but we are anticipating that allocation to increase very, very quickly as we tip into 2021 and move into early to mid 2021. We anticipate that will start tipping the other direction, and that we have a very large amount of allocation, and we will be able to push out vaccine to ultimately general population, hopefully by early to mid 2021. And then this graphic also indicates some kind of phase 3 vaccination. I think we all are kind of understanding that this is not going to be a one-time push. This will be something that we will have to stay on and stay after for a while. And then of course, we don't know what the revaccination strategy is going to look like. Is this going to be something that's an annual vaccination? We just simply don't know. That data is not available to us yet, and will have to be something that we're watching over time. So a little bit about the details. So the United States government has contracted with 6 manufacturers to produce COVID-19 vaccine. 5 of those 6 vaccines are 2-dose series, with only 1 being proposed as a 1-dose at this time. We are anticipating 2 at the beginning, the Moderna product and the Pfizer product, and more specifically, it's looking like Pfizer is going to be first at this time. Of course, everything I'm telling you is subject to change because that's kind of been the name of the game. But right now, at this moment in time, it looks like Pfizer may be the first to release. Some interesting things around these vaccines, specifically the Pfizer vaccine. The Pfizer vaccine is stored at -70°C, at ultra cold storage. So as you can imagine, and as your experience tells you, this is going to be a logistically challenging vaccine response at the beginning as we deal with this interesting storage and handling situation. It's also important to note here that these vaccines are not interchangeable. So if you start with the Pfizer product, you have to end with the Pfizer product for the 2-dose series, etc. So we have a lot of planning efforts going into that piece of it, because it's going to be a large lift, not only to get that patient back for their 2nd dose, but then to have to track and keep track of what vaccine that they should be receiving. We do know that there will be limited federal facilities that will be receiving their own COVID-19 vaccine allocation, and also corporate pharmacies. So it has been announced, which I think I have on my next slide, but CVS and Walgreens will be working to vaccinate residents of long-term care facilities. So the pharmacy piece has 2 pieces to it. We have the long-term care facility component with Walgreens and CVS. And then we have another component that we are anticipating coming a little later on when we start getting into vaccinating larger groups of people, potentially 65 and older, underlying health conditions, comorbidities, things like that. The federal government is going into contract with many chain pharmacies, larger chain pharmacies, and will be allocating vaccine directly to them. Tribal jurisdictions can choose to receive federal or state allocation. So we have been reaching out to our tribal partners across the state to encourage them to make their decision, whether they will receive that from the federal government or whether they will receive that from us. And also, so the state itself, the Nevada State Immunization Program, will be responsible for the state allocation of COVID-19 vaccine. So that means that all of our immunizing providers, much like the Vaccines for Children program or 317 program or any type of publicly funded vaccine program, all of those providers will have to enroll into the COVID-19 vaccine or pandemic provider program in order to receive state allocated vaccine. And then it will function very similarly to the VFC program. These providers will be ordering vaccine from or will be allocated vaccine from the Nevada State Immunization Program, us. At the beginning, we're anticipating an allocation model because we are going to be under very tight vaccine parameters. We're only going to have a very small amount of doses to work with. And then we'll be tipping into a more of an ordering system as we increase the number of providers that are being enrolled. Okay, so again, vaccine will be limited at the beginning. Vaccine will come with limited supplies. Limited PPE, syringes, needles, alcohol prep pads, that will all be coming with the vaccine itself. Notably not included in the vaccine shipment is bandages and sharps containers and additional PPE. It only comes with a few masks and things like that for the vaccinators. As I mentioned, vaccine allocation is going to increase very quickly through 2021, and as we tip into 2020, and as we tip into 2021, excuse me. So we are anticipating only being under this limited allocation for hopefully a relatively short amount of time. It is the federal government's goal that there will be 660 cumulative doses of COVID-19 vaccine, 660 million cumulative doses of COVID-19 vaccine to be available to Americans sometime in 2021. again, we have developed a phased population groups for healthcare workers first, critical infrastructure personnel, older adults, adults with underlying health conditions or comorbidities, etc. And we'll go into a little bit more detail with that in just a moment. And then, of course, CVS and Walgreens, as I mentioned, will be serving long-term care facility residents. Those staff at long-term care facilities will be served a little differently, and we can talk through that in a few moments as well. So a little bit more about phased vaccination strategy. So we will be starting with frontline healthcare workers and then the rest of healthcare workers. So we are working with the Nevada Hospital Association, the Nevada Rural Hospital Partners to define and quantify frontline healthcare workers in our acute care settings. We will be working through those first, and then we will be allocating to the rest of the hospitals and then the rest of healthcare workers first. Those would be our priority populations. We will then be moving on to critical infrastructure workforce. Also, other considerations that we have and that are listed on our priority lists are Nevadans living in congregate settings, those experiencing homelessness, of course, Nevadans who are 65 years and older, and those who have underlying or comorbid health conditions, and then ultimately the general public. It is important to note here that in the current clinical trials, there are no pregnant women or children. I think the lowest the age goes to, and one of them is 16 from my memory. So we are not anticipating a vaccine to be released for children or women or pregnant women at this time. So this is the first group that we are anticipating. You see we have a quantified here on the side. We have an allocation table that we have built that allocates it by county, and I'll talk about that in a little bit. So again, starting with the hospitals, moving on to long-term care facilities, psychiatric and substance abuse hospitals, our first responders, our frontline public health workforce, often our vaccinators, laboratory workers, and COVID testers, I should say, laboratory workers, pharmacists, pharmacy technicians, outpatient and home health providers, and then we start moving into public safety at the bottom of tier 1. This is the criteria that we considered when developing this phased priority list. The level of exposure to COVID-19. So this may be a population that has unavoidable and close contact with those who may have COVID-19. The length of exposure. So population may have unavoidable and sustained contact with those who have COVID-19. Importance of their job or special technical skill. So this could be someone that has a technical skill that's not easily replaced, like a physician or a utility worker or a teacher, or someone who works at a meat packing plant, something that that particular group does that the rest of us depend on for our safety and well-being. The likelihood of increasing community spread. So there could be populations that would have increased community or increased spread within a community or within a closed residential facility. Mortality rate, morbidity rate, and of course, another thing that we factored in is immune response regarding, of course, some of these, it is often the case that vaccines don't work as well in as a person ages. That's something that we took into consideration, but again, we'll have to wait for the clinical trial data to be released so we can make a more sound decision based in science on that piece when we have that data available to us. And then, of course, the other piece to this, and Dr. Pam Forrest will go into this a little bit more detail, but of course, we're waiting on the Advisory Committee on Immunization Practices to release their guidance and what they think. So we built this, our framework, modular, so we could pick it up and move it and place it in different places as needed as the ACIP meets and puts forth their recommendations. So allocation, so as I mentioned, because we are anticipating these doses to be extremely limited at the beginning, we have established a methodology that for allocation. So just in case we don't have enough to do every county at one time, So right now, the methodology is approved. The methodology used by the governor's COVID-19 mitigation and management task force to monitor county level disease transmission. And this particular methodology looks for counties to be flagged for elevated disease transmission if it meets two of these three criteria down below. That is currently what we are planning on doing. However, I will tell you that we are in conversation with Nevada Hospital Association and Nevada Rural Hospital Partners and some of our local health authorities to take a deeper dive for hospital-based allocation, because there may be some other considerations that we need to make. And so we're working hand in hand with those partners to be able to make those joint decisions to best serve the state and make the best decisions that we have or that we can to serve the populations, even if we don't have enough vaccine to cover all of our frontline healthcare workers. So where are we at right now? So we are currently really focused in on how to vaccinate our healthcare workers, frontline healthcare workers, the rest of our healthcare workers, and then ultimately starting to move on to that critical infrastructure, but really focused in on what we're calling tier 1 right now, which is that list that I showed you a few slides ago. Our efforts are really focused there because we need to have a solid plan in place, because this vaccine's coming in a hopefully not so distant future. So that being said, we have been focused on who is going to be responsible for vaccinating those people and getting those particular providers enrolled into the program first, and then we'll be able to move on and open up that provider enrollment ultimately, hopefully over the coming weeks and months ahead. So right now, we are anticipating that all tier 1 people will be vaccinated either at the hospital that they work at, or they will be invited to a closed vaccination event hosted by their local health authority. So we have been enrolling local health authorities, rural community health nursing offices, acute care hospitals, and any other provider identified that would be serving healthcare workers and frontline personnel. So again, each Nevada community, of course, is different. So we are making these decisions with emergency managers and local health authorities to ensure that each Nevada community is being met where they are and has a plan in place to be able to get this tier 1 vaccination group done. I'm hoping over the next week or two that we're going to be able to really solidify our tier 1 plans, because we need to move on and figure out what we want to do next, which will be our tier 2 and beyond, so we can start focusing on enrolling more providers, because as I indicated earlier, that vaccine allocation is anticipated to increase pretty quickly. So we have to be able to move on and know what we're doing next after we get our feet under us a little bit more with this tier 1 group. So data. Of course, when we're dealing with any type of COVID-19 or any type of pandemic, specifically this COVID-19 pandemic, we need data. We need data to drive our decisions. We need data to understand where we are, what our status currently is. Fortunately for Nevada, Nevada WebIZ has a statewide immunization information system, which I'm sure many of you are familiar with. It has been around for years and it is widely used. There is a state mandate that says, state law that requires any vaccine that's given in the state of Nevada be input into Nevada WebIZ. So Nevada WebIZ will remain that main system for Nevada for vaccine ordering and documentation, to remind Nevadans of that second dose, and just serve as that primary tool for providers to use throughout the COVID-19 vaccine response. We've also created a simple REDCap survey, which a REDCap is just a database with an external link for folks to enter data into to collect aggregate data. The reason we are doing this is because we're using it as an evaluation tool. So we want to understand how many frontline healthcare workers are being vaccinated, and Nevada WebIZ doesn't have a way to record occupation or tiered priority group that particular person is falling into. So we want to be able to understand and evaluate where we are at as a state and be able to make decisions based upon that, utilizing that data. It is important to note here that vaccine administration data must be reported to the CDC every 24 hours. So we are doing that. That is part of our requirements as we move through this vaccine response. But there is a very large federal push for real-time data coming out of the state, and they want to understand that vaccine throughput and see how much uptake there is in the states, etc. And Pam, would you mind talking about storage and handling? I feel like you might be a better one to talk about that.
Can you hear me?
Yeah.
Okay. The vaccines that are currently being manufactured, some require refrigeration, and of course that's 2 to 8 degrees Celsius or 36 to 46 degrees Fahrenheit. Some of the other preparations require a freezer, and so the provider would have to have a standalone freezer, not a combination unit, but standalone unit. And the temperature would have to be maintained at minus 20 degrees Celsius or colder, which is minus 4 Fahrenheit or colder. Now that's different than what providers are used to. The varicella vaccine has to be stored at 5 degrees Fahrenheit or colder. So some of our providers are going to have to turn down the freezer temps so that they get colder to satisfy this requirement. And digital data loggers will be required in each unit because we want temperature readings 24 hours a day, 7 days a week to ensure that the vaccine has been stored properly so that it's safe and effective to use. And we will require providers to send us their temperature data at least once a month. And then there's the Pfizer vaccine, I should also mention, that has to be stored at ultra cold temperatures, which is minus 70 degrees Celsius. And you have to have a special ultra cold freezer to store that. That product will arrive in a thermal shipping container filled with dry ice. The container will weigh 60 pounds because it has 50 pounds of dry ice in it. With replenishing the dry ice, the vaccine can be maintained in the shipping container for 10 days, and then it can be stored in the refrigerator for an additional 5 days. We have identified ultra-cold freezers across the state, and plans are being made to house the ultra-cold vaccine in the freezers and then transport them to the hospitals so that they can start vaccinating their healthcare workers. The ultra-cold vaccine, the minimum order that you can get is 975 doses. So that's why we have to have the ultra-cold vaccine stored in a central location and then transported out to the hospitals. And this will take a lot of communication with us so that we coordinate with the hospitals so that we get the vaccine to them on the days that they have their points of dispensing planned for.
Yeah, and I'll just add in on that. Thank you, Pam. I'll just add in on that at the beginning, we will be redistributing. That's the current planning assumption. We will be redistributing all of those ultra cold vaccines at the beginning. That may change over time, but it appears that the method moving forward at the beginning is going to be us redistributing. So that it's going to be us, as Pam indicated, working with hospitals, working with our local health authorities to make sure that we have a communication set up and we can deliver vaccine across the state. And we're really setting ourselves up to be able to travel. We're calling it the corridors, the I-80, the 50, the 95 corridor, and take that vaccine wherever it may need to go to serve all of Nevada. All right, Pam, it is all you. Thank you.
Okay. Well, unfortunately, vaccine hesitancy is in the news frequently these days. You read about it in the newspaper, hear about it on the radio, it's on TV, and in social media. By reviewing the vaccine clinical trial process with you today, my hope is that this information will reassure you that the standard procedures are being adhered to during the development of the COVID-19 vaccine. Initially, vaccines are tested in animals. If no adverse events occur, the vaccine developers proceed to human trials. This is a nice infographic created by the CDC, and you can see in phase 1 of the human clinical trials, only 20 to 100 healthy adults are enrolled. Different dosages of the vaccine are administered to the participants. In the Pfizer study, they had groups of 15, and I think they tried first 4 different strengths of the vaccine. At the end of phase 1, the dosage of the vaccine that generated the best immune response with the lowest side effects was selected. So let's talk about side effects for a moment. Local reactions such as injection site redness, swelling, warmth are a sign that the immune system is working. Systemic reactions such as fever, headache, and fatigue, again, are a sign that the immune system is responding to the vaccine. While expected reactions, such as the ones I mentioned, are recorded, the study also monitors participants for the unexpected adverse events. All participants in the COVID-19 vaccine clinical trials will be monitored for 1 year after their booster dose. In phase 2, hundreds of participants are recruited to receive the vaccine. Safety and immune response are determined among various ages and races and ethnic groups. In phase 3, tens of thousands of participants are recruited to receive the vaccine. Again, during this phase, safety and efficacy are monitored. In the current clinical trials of the COVID-19 vaccine, as Shannon mentioned, no children or pregnant women are involved. Pfizer has recently announced that they are enrolling children or teens down to the age of 12. And the oldest person in the trials is 85 years. Can we go to the next slide? Operation Warp Speed has accelerated this standard process. The top bar describes the clinical process, the typical process, and the accelerated process is in the bar beneath that. So as you can see, it's the same colored bars, it's just compressed. So in the beginning, fortunately, an mRNA vaccine platform that Pfizer and Moderna are currently utilizing, that platform already existed. So that saved time in the research and development phase. So they were able to combine the research and development and phase 1. Phases 2 and 3 were combined. Pfizer to date has enrolled 44,000 participants, and Moderna has enrolled at least 25,000 participants. Usually companies manufacture the vaccine after clinical trials have concluded. So as you can see on the top bar, they progress through the 3 different types of clinical trials, and then the brown rectangle is the manufacturing time. In the accelerated process, as you can see, the brown rectangle extends from the start of phase 2 clinical trials. And so we will have, when the trials end and this vaccine is licensed or gets an emergency use authorization, there will be millions of doses of vaccine waiting because the manufacturing has been progressing all along. Distribution plans are forming right now so that the COVID-19 vaccine can quickly become available across the United States. So as you can see, usually the distribution takes 6 months. The government is hoping to get the vaccine out within 3 months. Next slide, please. We had a phone call with General Perna. He is the person in charge of Operation Warp Speed. And he has assured us that the government is taking the financial risk. However, safety is very important. And if it is determined that the COVID-19 vaccines are not safe or effective, they will be disposed of. Next slide, please. Now, during this whole process, there are independent review boards. During the manufacturing process, the Data Safety Monitoring Board was reviewing the clinical trial data. This board is composed of researchers, scientists, clinicians, professors, people outside of the FDA, and they have no ties to the manufacturer. When the clinical trials have concluded, the Vaccine and Related Biologic Product Advisory Committee will meet. They will review the data. And again, this body of scientists and vaccine experts is completely outside of the FDA and the manufacturer. This independent review board will tell the FDA whether they recommend the vaccine to be licensed or whether to bestow the emergency use authorization on it. So then the FDA meets and they either license it or make it an EUA product. And then finally, the Advisory Committee on Immunization Practices meets. And as we all know, the ACIP is a very powerful group. They are, again, not affiliated with the manufacturer or the FDA. The Advisory Committee on Immunization Practices makes the schedules that all physicians in the United States follow. Whatever the ACIP votes upon, it's endorsed by the AAP and the AAFP and the American College of Obstetrics and Gynecology. So as you can see, the approval process for COVID-19 vaccine is progressing the same as a childhood vaccine does, or our yearly influenza vaccine and other other traditional vaccines. So we can all be confident that when this product finally comes to market, that it's safe and effective. Back to you, Shannon.
Okay, and since it is almost Nevada Day, I feel like it's my very last time to just say, don't forget to get your flu shot. So that is what we have to say today, but happy to take questions. Anything you want to know, we will try our best to answer.
Shannon, I think people can either unmute themselves or they can put a question in the chat, whichever is easier for them.
Are you chatting or yourself?
I'm gonna unmute. Thanks. Every time I hear this presentation, you guys are nailing. It's getting better. It's really it's going to be interesting to see where we go from here. And I really want to thank you guys for getting this information out there. One thing that I've been reading, and I don't know, Dr. Forrest, if you might be able to comment on, is I did see some things where the FDA was talking about maybe not doing an emergency or not approving it, but doing like a compassionate use authorization. And I was just wondering if you've heard anything about that, and what the status of that might be.
I read about it in the Journal of American Medical Association. They had a nice article where they mentioned that I was only aware that they could license it or use EUA. And then after I read that article, I read about the compassionate use. So I don't know if it'll be used or not.
And then another question, I guess. So if there are providers who are currently not doing immunizations, who hear this talk and are motivated to get in the vaccination game and sign up and to be able to give the COVID vaccine in their offices, what's the easiest, best way for them to do that?
Yeah, I mean, that's a great question. I'm sure Pam would probably have some insight to that as well. But if you are interested in providing COVID-19 vaccine, or if there's any provider that is, it is our goal to enroll a large amount of providers. I think for H1N1, we enrolled over 1,000 new providers in 2009. So I anticipate this will be bigger than that even. So if you are interested, please do let us know. I'll put our email address in the chat box. Thank you, Pam. You are so quick. There's an email in the chat box. Feel free to email us and tell us you're interested. Just know that it's going to be this phased approach. We will likely be reaching out to a large portion of providers in a month or two as we really start getting that allocation and get our first couple tiers vaccinated. And then maybe Pam would want to talk about some storage and handling requirements and things like that to get set up. Anything else you have to add, Pam?
As I mentioned before, you'll have to have standalone refrigerator or a standalone freezer, and both units will have to have continuous monitoring. So you'll have to have data loggers. And then we always like you to label your outlet with the do not unplug sticker, and you find your circuit breaker that supplies the power to your units and label that with a do not turn off sticker. Because we have lost tens of thousands of dollars of vaccine because offices have work done when nobody's there and the electrician turns off the power. And then the office staff comes in and they find their nice warm vaccines on Monday morning. And it's very upsetting to start your week that way. So.
I have a question.
Yes, please.
Is there going to be guidelines for immunocompromised patients? All immunocompromised patients can come in a different variety of ways. So is there going to be a guidelines as to which immunocompromised patients get vaccinated and who does not? Is there some contraindication in any of the vaccines that are available for immunocompromised patients, organ transplants, et cetera?
You know, the ACIP will tell us who should receive the vaccines, and they have the ultimate say after reviewing all the data.
Thank you.
Just another question. So with wave one and the healthcare professionals in the hospitals, do you guys, is the plan to sort of turn over, figure out an allocation and turn those over to the hospitals and let the hospitals decide among, within that hospital system of who's going to get the, who should get which physicians and healthcare providers are going to get the vaccine first? Or are you guys going to kind of say, here's the vaccines, but here's who we think should be getting it first? Or how's that going to work?
I think it should be up to the hospital. The trick with that is we do have to have some kind of numbers to go off of because it's all about, our allocation. So we are anticipating, we're enrolling all of the hospitals right now so they can actually have this vaccine. And, as Dr. Forrest indicated earlier, the ultra cold vaccine can be stored in the refrigerator for 5 days, I believe. So we can give it to them and they can do their vaccinations the way that they see fit to who they see fit. But we are working with the Hospital Association and Nevada Rural Hospital Partners on the details of that, because like I said, we do have to quantify it. But again, and they're helping us do that and helping us define and give the hospital some ideas as to what we are thinking. And then the ultimate goal, though, is to support the hospitals in choosing those particular frontline people as they see fit.
Do we have any other questions? I am going to put a link in the chat. Immunize Nevada has a new COVID-19 vaccine planning page, and we are updating this page with regular resources. Just today, we added a new frequently asked questions section. So the same email that Pam put in the chat, you can actually email right off this page and it will go to them. And then if it's a question that's applicable to others, we will be adding it to the frequently asked questions, which are at the bottom of that page. This recording will be posted on our vaccine planning YouTube playlist, and there's a number of other video resources on that list already.
And I think, you know, our message right now is we're here. If you have questions, if you're struggling with something in your community that you don't know how to approach or you don't know how it's going to work, let us know and we will do our best to get your question answered. My only caution is that this has been ever changing and extremely fluid. So what I tell you today might be different tomorrow, but I will tell you what I know.
Thanks. I think this is incredibly helpful. I'm wondering if we might be able to think about, you know, once a vaccine gets approved or vaccines or whatever, would we be able to have another one of these? Because I'm sure there's going to be a lot of specific questions when the vaccine gets approved. So I'm just wondering if we can maybe think about, you know, hopefully in 3-4 weeks or whatever, or 5 or 6 or whatever this gets approved, if we could do something like this again, because like I said, that's probably going to be the next issue, is a lot of the specific questions.
During H1N1, we had provider phone calls at lunchtime every Wednesday. And we had great discussions every Wednesday. So if that time would be convenient, we can do that. Or if evening is better, you let us know.
Okay, we'll sort of talk about it amongst the groups. I think for a lot of the people who are providing vaccinations, actually, lunchtime never works for the surgical folks, but for a lot of the primary.
They won't be providing.
But yeah,
getting
right.
it.
A lot of the offices providing it, lunchtime might work. So we'll sort of chat about. We'll talk about it with Jaron and get back to you. But something like that, because I think communication on this is just going to be so vital. You guys are doing such a great job with it.
Yes,
Yeah.
Thank you so much. This is Jaron. I just want to echo what Dr. Pasternak said. You've all been phenomenal. Heidi and Shannon, thank you so much for this. And whatever NSMA, Dr. Pasternak, and whomever we can do to help, please let us know.
We really appreciate it. We appreciate the questions. We appreciate the engagement. You know, this is not this is no small feat, man. This is going to be an all hands on deck situation, and we understand that, and we can't do it without our partners. So we appreciate you guys being here. We appreciate your interest, and please let us know what we can do to help you get the job done in your communities as well.